So let's move a little bit now towards the evaluation of the tender testis. Scrotal pain is probably one of the most common complaints that people come in for, where we do ultrasound of the testis, especially young men. Epididymitis is perhaps the most common cause of acute scrotum. And here what you use is the Doppler flow to show you that this is a normal looking testis. Here's your epididymis. The epididymis may be a little bit enlarged here. It may be tender when you put the ultrasound probe on the epididymis. And when you use the Doppler evaluation, you can see that there's markedly increased Doppler flow in this epididymis. So this is clearly diagnostic of epididymitis. Remember, there should be very little to no flow normally in that epididymis. Orchitis is an inflammation of the testis itself. Sometimes on the gray scale, you can actually see there's a heterogeneous pattern in a testicle. Testicle may be enlarged. And once again, with Doppler flow, we see markedly increased Doppler flow in the testis. If the symptoms are just on one side, if they're unilateral symptoms, you can use that median Raphe view to show that there's more flow on the side of the tenderness. Often the two come together, that is epididymitis and orchitis, so we get epididymal orchitis. Here we have an example of a mildly heterogeneous testicle with a very heterogeneous and hypoechoic area inside this epididymis, and increased Doppler flow in the testis as well as in the epididymis, tenderness on the side of the flow, so this is diagnostic of epididymal orchitis. Another case of epididymal orchitis, testis, increased flow. Adjacent to the testis is the epididymis here with increased flow. And look at the planes of the tissue surrounding the testis. The scrotum here is very thick-walled. So we have epididymal orchitis with inflammatory changes in the scrotum and a very small hydrocele here between the scrotal wall and the testis. See that hydrocele is anterior to the testis but does not appear back here behind the testis. Moving along, if the epididymitis or orchitis is not treated, and it progresses, it could actually progress into an abscess. Here we see scrotal abscesses, low-level echogenic material within the fluid here. So we have dirty fluid basically on ultrasound. It can have septations in it that loculates it off into different compartments. There can be residual material or debris sitting within these fluid collections. This is very common for scrotal abscesses. So you put the Doppler on, you'll see increased flow around the periphery of the abscess because of the inflammation. Here's a nice case of TB orchitis, short axis and long axis views of the testis. Notice the increased flow in this testis, the increased flow around the testis. Here's increased flow again in the sagittal view. But this is really indistinguishable from any other orchitis. We happen to know this patient had TB orchitis. Here's sort of the opposite situation, where the scrotum actually is very thick-walled, but the testis itself and the epididymis were both normal and had normal flow patterns, but the scrotal wall was thickened. So this was fasciitis, or an inflammation of the skin of the scrotum without involvement as an orchitis. This is actually a very interesting case. This next patient was a known sarcoid patient who had scrotal involvement. Scrotal involvement is actually relatively rare in sarcoid, but it's seen in up to 1% of patients. In general, the epididymal involvement is more common than the testicular involvement, but whether it's in the epididymis where you're seeing hypoechoic areas, or whether it's in the testicle itself where you're seeing hypoechoic foci, the hypoechoic foci are classic for scrotal sarcoidosis. They're not specific for it, but in the right setting, you can make that diagnosis, and these small hypoechoic masses can calcify. Of note, it's very difficult to distinguish them from tumors, so if you only have one of them, you may run into an issue. But we're on the topic of testicular inflammation. We're talking about the acute testis, the acute scrotum. Someone comes in with a painful scrotum. 80% of the time, that's going to be related to epididymitis or orchitis or epididymal orchitis. However, in a minority of cases, it will be related to testicular torsion. And it's very important, it's critical to find this early in order to save the testicle. If you can find this within 24 hours and operate on it, you have a good chance of salvaging that testicle. If you don't find it, then there's a good chance the testicle will be lost to infarction. Why does this happen? It happens because of what's called a bell clapper deformity. Remember, we had said that the tunica vaginalis is tacked to the posterior wall of the scrotum, so it surrounds the scrotum anteriorly and laterally, superiorly and inferiorly, but not posteriorly. In the bell clapper deformity, the tunica surrounds the entire testis, and so there's nothing pinning the testis back to the scrotum. The testis is able to move freely, and it can actually twist on its stalk, and so you can end up with torsion of the testis and obstruction of the vascular flow in the spermatic cord. There is that's the intravaginal torsion, which is the standard type of torsion, normally seen. If it's going to happen, it's often seen in the early teens, and that would be a common complaint for a young teenager coming in with testicular pain. Extravaginal torsion is another type of torsion which tends to occur in neonates. What happens with the torsion? Well, the problem is the testicle is twisting on the spermatic cord, and so instead of having good flow throughout the testis here, what you're seeing is that some of the vascular supply to the testis has been obstructed, and so you've ended up with an infarct to this portion of the testis. This portion of the testis no longer has flow. It's no longer alive. There's a small amount of flow here in this part of the testis, and look what's happened. The infarcted portion of the testis has a very different echo texture because the testicular material here has become necrotic as compared to the normal residual testis here where there was some flow. So ultrasound is a great way of distinguishing now between epididymal orchitis, which we've seen in previous slides had increased flow, and between torsion, which has decreased flow. But there are multiple findings of torsion on grayscale. You can see a heterogeneous testis, could be enlarged. Late on, it could be atrophic. But the early findings of a heterogeneous enlarged testis, these are overlapping now between torsion and between inflammation or orchitis. However, Doppler can distinguish torsion from epididymitis because on the tender side, orchitis epididymitis will have increased flow on the side of tenderness, whereas torsion will have decreased flow on the side of tenderness. And early on, you may first obstruct the venous flow, and if the torsion is twisted a little further, you may obstruct the arterial flow as well. Moving on with the post-traumatic findings that one can see in a testicle. So long view, short axis view of a testicle. Post-trauma, we see here that the surface of the testicle is still smooth because there's an intact tunica albuginea, but there is a unusual sort of mass-occupying lesion here, and this is a contusion of the testis. In the appropriate clinical setting, young boy just played football, got hit in the testis. This is obviously going to be a contusion. You can see here, this is the Doppler flow with color Doppler, with power Doppler. The normal testis has flow. The contused area does not demonstrate the presence of flow. Now, the previous example, the testicle itself was intact, and you saw the smooth border. This is another post-traumatic example, but here we see that instead of a smooth testicular margin, there is a lumpy, bumpy kind of margin of stuff. Looks like spaghetti coming out of the testicle. And this is testicular rupture. So here the tunica albuginea is no longer intact. There's a heterogeneous testicle. The testicular contents are protruding into a hydrocele, which is now surrounding the testicle. It can be difficult to distinguish these contents from hemorrhage in the scrotum. Doppler identifies normal testicular tissue, so we use a Doppler here just to show that there is flow in the testicular tissue. If you do surgery immediately, the salvage rate can still be relatively high. Next, we're just going to move on to some benign findings in the testicle, which are important to recognize because they are leave me alone findings. This is a transverse image of a testicle. On the margin of the testicle, we see a small cyst. It's anechoic. It has through transmission. This is a tunica albuginea cyst. Often they are multiple. Usually they're small, and they can be seen around the periphery of the testicle. They have absolutely no significance. Parenchymal cysts are also possible within the testis. They can be near the mediastinum testis. They're often associated with epididymal cysts, and they can be up to 2 centimeters in size. In addition to cysts, one can see calcifications along the tunica. If it moves around, you would call it a scrotal pearl. If it doesn't, it may just be a calcification of the tunica related to previous inflammation. In any event, if the patient's not symptomatic, it's a leave me alone lesion. Important to see it and recognize it as a benign post-inflammatory process. Now, when we talked before about dilatation of the vitae testis, I mentioned that that could be associated with epididymal cysts or spermatoceles. And here we see some examples. This is the testis here, and this is the epididymis. And in the epididymis, there is a cyst. And here's another example of cyst in the epididymis, and yet another cyst in the epididymis. Two types of cysts, epididymal cyst versus spermatocele. Both may be related to prior trauma or epididymitis. However, the cyst is going to have just clear fluid in it, whereas the spermatocele has spermatozoa in it, and may have thick milky fluid. Usually we don't know the difference because we don't really care. They're both benign findings, and no one's going to aspirate it. But if you were to aspirate, you'd be able to easily tell a spermatic cyst from a spermatocele. Spermatoceles are often seen incidentally in older men, and often they are multiple.